Ava. I know we've been busy, but I just saw a patient. I want to go ahead and give you a report on her. Okay? Mrs. L is a morbidly obese 15-year-old female with a BMI of 56 and no other PERT negatives who presents to the ED today complaining of knee pain after sustaining a fall just prior to arrival. Prior to the fall, she felt her knee kind of lock up, and then she tried to take another step, and she felt her knee give out, which actually caused the fall. She describes the pain as an immediate, sharp pain to the front part of her knee. It's exacerbated with any kind of ambulation or any kind of weight bearing, and it is decreased when she is able to rest. She noted that she has not taken anything to alleviate the pain. She also denies hitting her head, losing consciousness, loss of coordination, vision changes, or any other symptoms or injuries. After checking her vitals, they seem a little bit unremarkable, but her blood pressure is a little elevated. It is 131/87, and her pulse is 98. Her respirations are 18 and regular. She's 98% on room air, and her temp is 98.9. And like I said, her BMI is 56. The patient denies tobacco use, alcohol use, or any illicit drug use. The cardiac and pulmonary exams were unremarkable. I did a neuro exam as well, and she had a coherent thought process, good muscle, bulk, and tone. Cranial nerves 2 through 12 were grossly intact. 5 out of 5 strength on her right lower extremity. I did pinprick and light touch, which were intact bilaterally in the lower extremities. Okay, so upon inspection of the left lower extremity, I noted a deformity in the left patellar region, although there was no significant erythema or ecchymosis noted in the area. Upon actual palpation of the anterior aspect of the knee, there's a lot of pain elicited. The patient is actually unable to actively flex at the knee joint, so when I was trying to passively move her knee at the knee joint, she was in a lot of pain and was uncomfortable and uncooperative for the rest of the exam. I attempted to check pedal pulses but was unable to palpate them. However, I did find them using the Doppler. Cap refill is less than 2 seconds, and her feet are both warm bilaterally. So for this patient, my top 3 differential diagnoses are patella dislocation, ACL, MCL meniscus tear, and a patella fracture secondary to morbid obesity. For the ACL, MCL meniscus, although it would not show up on an x-ray, it is still possible after taking the patient's history and learning her mechanism of action of the incident that this could be a possibility. The knee was strained and it caused her to fall. If this were the diagnosis, I would obtain an MRI of the knee, give the patient oral medications because she is in severe pain. If the x-ray was negative for dislocation or fracture, I would order order an MRI for the ACL meniscus MCL tear. If the tear is confirmed, I'd consult ortho, the surgery team. The leg will be in an immobilizer until a specific diagnosis is confirmed. The ortho team will determine if the patient's injury requires surgery, and follow-up with ortho will be necessary. Second, a patella fracture. Because this is a pediatric patient and she is morbidly obese, it is possible that the growth plate of the knee was crushed from some overuse. If this were the diagnosis, I would obtain imaging of the left lower extremity and hip, give the patient oral medications because she is in a lot of pain, and if the fracture is confirmed, I'd consult the ortho surgery team. Sometimes these type of fractures can be occult on radiography, so a CT could be ordered to look at the orientation of the epiphyseal plate. If the fracture does not require surgery, other plans of actions will be considered. Follow-up with ortho will definitely be necessary. So actually, upon reviewing the patient's left lower extremity, my top differential diagnosis is a patella dislocation. The decision arises from the physical exam and the imaging I obtained. Imaging actually shows lateral displacement of the left patella with a joint effusion and is positive for the sliver sign, which is highly suggestive of a patella dislocation. The next step would be to order an MRI to check for any ligamentous injuries, and then relocate the patella into the trochlear groove. The ortho team will determine whether the patient needs surgical intervention. If it doesn't, immobilization and extension for 3 to 6 weeks, followed by rehabilitation will be the plan of care and expected to be a full recovery, although this can happen multiple times throughout her life, so she would need to be educated on that as well. All right, do you have any questions?
Now, brown cow. Listen to this.
15-year-old morbidly obese Mrs. L is a 15-year-old morbidly obese female. Miss L is a 15-year-old morbidly obese female. Mrs. L is a 15-year-old morbidly obese